I'd like to welcome everybody to today's webinar titled Complying with Federal Regulations for Interoperability and Electronic Notifications. I would like to thank all of our presenters for taking the time to share their message with you guys today, with the attendees. Our presenters include Dan Paoletti, who's the CEO of the CliniSync Health Information Exchange, Mr. Dave Zupkovich, who is our Application and Web Services Manager here at CliniSync, Alan Killworth, who's a partner of Bricker and Eckler and also serves as our outside counsel for the CliniSync HIE team, Missi Thomas, Director of IT from NOMS Healthcare, Stephanie Huntington, Clinical IT Analyst from NOMS Healthcare, and Michelle Naugle, IT Clinical Advocate at NOMS Healthcare. With that, I'm going to turn it over to Mr. Dan Paoletti.
Good afternoon, everybody, and thank you for joining today. I am going to go through my slides fairly quickly because I'm probably the least important speaker on today's webinar. But again, I can answer any questions that you put through the chat towards the end. We want to save time for that. So just as a reminder, the Ohio Health Information Partnership and CliniSync, we are a nonprofit 501c3. We are an independent entity governed by a 17-member board, an advisory council, as well as our executive group and founders. And again, we are fully funded by our stakeholders for services that we provide. Next slide, Scott. We're really going to focus today's conversation and the series of conversations that we're going to have over the next several months around interoperability and how through CliniSync we are attempting to complement your interoperability strategies and bringing additional value through the work that we are doing with you. And again, that is possible because of the broad participation we have in the state. We are rather unique from a health information exchange perspective. Again, being financially independent and having such broad stakeholder participation, it allows us to do things like help you comply with these new COP rules. Next slide, Scott. In addition to the hospital vendors that we are working with, we are integrated with over 60 ambulatory and post-acute care vendors, which helps complement a lot of the interoperability strategies that we'll talk about today in the near future. Next slide. Again, what makes it possible to help comply with the ADT notification rules is the fact that we are working with so many hospitals currently, 155 in the production environment. All of those are currently supplying information that is required to meet the new COP rules. Next slide. When we talk about the broader interoperability strategies, again, we're expanding the data contribution and interoperability to the non-hospital sites to include ambulatory and post-acute care, and that list grows every day, and this information can be made available to you upon request, and I believe is on our website as well. Next slide. But let's focus again, bring it back to, again, interoperability, specifically the 21st Century Cures Act and what came out of that, the new COP around ADT hospital notifications. Next slide. Again, the effective date for the hospital participation will be, at least as of today, is May 1st in 2021. The reality is for most of you on the phone that are working with us, you are already in compliance with that rule as we move through the rest of the webinar. But again, that's the date that this will begin from a reporting perspective for you. Next slide. And again, when we talk about the broader interoperability, there's lots of services that we provide. Again, we'll be talking about this on future webinars, in addition to how we will help you stand up to any claim of information blocking as that rule goes into place. But again, today, the service we're going to focus on is the notifications that we are able to provide on your behalf as the third-party entity that you're working with for your admissions, discharges, and emergency room visits. Next slide, Scott. Currently, every hospital receives a quarterly report, and this is an example. This is the CliniSync wide report. And again, this talks about more of a global interoperability strategy. But on the third line down, you will see the alerts and notifications to the community. As you can see, over the last 12 months, we've sent almost 28 million notifications out to treating providers and other post-acute care facilities for patients that they are treating that were also seen in the hospitals we're working with. So again, as I mentioned earlier, we are already doing this. We've been doing this for a while. We've made a few changes to help be more in compliance with the new rule. But again, this is an example of the work is already in place. Next slide. And as I mentioned, every hospital gets the individual aggregate report every quarter, the example that we showed on the previous slide. Again, and it talks about all of the interoperability efforts that you're working with us on. The notifications, again, not only shows you the alerts that are going out to the community, but if you are also signed up to receive them, the alerts from the community that are coming back to you. And again, we will have additional detail available to you if needed to show you exactly who are receiving those notifications on your behalf. So again, the data needed to comply with this rule is already being received by CliniSync. The technology is already in place and working, and again, the documentation and the reports are already in place as well. We will be adding some additional detail to the documentation as we get closer to the May timeline. Next slide, Scott. With that, again, as I mentioned, I wanted to go through mine fairly quickly. I want to turn it over to Alan Killworth with Brooker and Eckler. We worked with Brooker and Eckler to do a legal opinion because, again, we wanted an outside review of all the information we are presenting you today. Brooker does so much great work in healthcare in the state. We thought they'd be a great group to work with on this. So with that, Alan, I'm going to go ahead and turn it over to you.
Great, thanks, Dan. I appreciate it. I'm going to, as Dan mentioned, my name is Alan Killworth. I'm an attorney at Brooker and Eckler here in Columbus, Ohio, and we wanted to cover the rule itself, the legal issues related to ADT notifications, and the requirements in the conditions of participation. We're happy to participate in this webinar and to serve that role. If any questions, obviously, I can hopefully, from the legal side, I can hopefully help answer those too. And this will sort of set the stage as background for the subsequent discussion after me on some of the functionality of CliniSync and some of the examples of the notifications that are being made and how they fit into this newly imposed regulatory framework. So you can go ahead and go to the next slide. The next couple of slides are just a sort of a really succinct summary of the rule itself. We didn't try to include all of the regulatory language. There's a citation there in this that I'll point out if you want to go to the rule itself and actually read the rule, if you want to torture yourself to read the law. But as mentioned, the ADT notification rule is part of the CMS final rule that was published on May 1st, 2020, along with the ONC final rule that were a companion set of rules for the Cures interoperability regulatory framework. The CMS final rule, which is just one of the two of those, but even that is a fairly large rule that has many different components. The ADT notification provision is just one of those, and that's what we're going to focus on today. The final rule established ADT notification requirements as a standard under the conditions of participation. For anyone not familiar with those are requirements for all hospitals that participate in the Medicare program that are required for hospitals to meet. So sort of baseline requirements for hospitals to participate in the Medicare program. There are actually three different COPs, or conditions of participation, that are established through the new rule for various types of hospitals: regular acute care hospitals, psychiatric hospitals, and critical access hospitals. Those are shown there in the fourth row of this slide with the citations that I mentioned before. So the hospital COP is now, as you can see, for acute care hospitals is at 42 CFR 42.24 subsection D. Those are existing conditions of participation that are all related to medical record services. And they've added these subsection Ds to these 3 different regulations to add the new standard within these conditions of participation regarding ADT notification. All 3 of the rules are essentially the same. They're nearly identical with some slight differences in wording for the different types of hospitals. And throughout this summary, I'll just refer to them collectively as sort of a single regulation, but there are 3 separate regulations depending on which type of hospital you are. As mentioned in Dan's introductory slides, these are effective on May 1st, 2021, due to an enforcement delay. Actually, they would have been effective earlier, but they delayed enforcement until May 1st, 2021. We have a note here on the type of enforcement, really in the 3rd row. We just want to point out that as a condition of participation, this requirement is enforced through the survey and certification process. So if CMS were to survey a hospital as part of a validation survey, for example, after May 1st, 2021, that survey would include checking to see if the hospital complies with this ADT notification standard. Because accrediting organizations are required to have their standards align with the CMS COPs, this would also be included in any AO or accrediting organization survey after that date as well, such as Joint Commission or HCAP. Those will all need to survey hospitals for this same requirement as well, because they have to survey to the CMS standards. As that, the enforcement process through the survey and certification is just like a general survey and certification. A penalty, there are no monetary penalties for that, for missing it, but it can jeopardize your ability to participate in Medicare, and the result of an ongoing deficiency of a condition of participation would be termination from the Medicare program. Turning to the requirements of the standard, note that it applies to hospitals and psych hospitals and critical access hospitals, but not to other types of facilities, not to other ASCs or other types of medical facilities, or to physicians, for example. It's a hospital-based standard for hospitals to send these notices out. It only applies also to hospitals that meet certain technical specifications, specifically the HL7 2.5.1 ADT feed standard. So if your system is conformant with that standard, you're required to meet you're required to comply with these ADT notification requirements. The rule requires that an electronic notification containing at least patient name, treating practitioner, and sending facility name is sent by hospitals upon certain events which are shown at the bottom of this slide, the bottom row of this slide. The notification events are patient registration in the emergency department, admission as an inpatient, and then lastly, discharge or transfer from the ED or from the inpatient service. So note that also that each one of these events requires a separate notification. So a hospital could have 3 different notification requirements with a patient visit. Patient goes to the ED, is admitted to an inpatient service, and then subsequently discharged. Those would be 3 separate notifications as each one occurs. Notice also that you're probably going to at least have 2 notification events in any type of scenario. It's hard to imagine a scenario where you wouldn't have 2. Obviously, the patient comes and goes, and each one of those is going to be a notice event. Okay, I should mention transfers within the hospital other than ED to inpatient. That one is included, of course. That would be a notification event. But transfers once they're inpatient, so from different unit to different unit, are not required to be included in these notifications. It's only ED to inpatient, then inpatient discharge. Okay, next slide. So in slide 15, we continue this overview, and we move on to who must receive the notifications. And there are a list of recipients that are required to receive the notifications. The hospital has to be able to send notifications to the recipients identified here in the first row, and there's really 2 categories. The first is the practitioner or group primarily responsible for the patient's care, which is determined by either who is already established as the patient's primary care practitioner or group, who is identified by the patient as that practitioner or group, or who is primarily identified as being primarily responsible for the patient's care. The second set, in addition to the practitioner who's primarily responsible, are post-acute care facilities. Dan referenced these earlier. These are SNFs, home health agencies, other hospitals even, those types of facilities that would have an ongoing post-acute relationship with the patient. And it's actually both before and after. If you look at the rule, and then it's summarized here, it's a post-acute care facility that either has an established care relationship immediately prior to admission. So if a patient's transferred to your hospital and is coming from, for example, a SNF, that would be a post-acute care facility. Or where the patient is being transferred to, where the patient is going immediately post-discharge. If the patient's being transferred from a hospital to a SNF or to another facility, obviously that would be included in the post-acute care facility. A couple notes on recipients, as shown in the next few rows. First, a hospital is permitted to follow practitioner instructions on these notifications, and hospitals then not required to send the notifications based on those instructions. So, for example, a practitioner that says, I only want to get discharge notifications, for example, a hospital is permitted to honor that request and does not need to send the other notifications, meaning the ED registration or the admission to an inpatient unit, to that particular practitioner. So it can be tailored towards a practitioner's preferences, or a practitioner in theory could say, I don't want to receive any notification, ADT notifications, and a hospital would be permitted to honor that and then would not be obligated to send those. Second, the rule recognizes that there might be primary care practitioners or there might not be a primary practitioner at all, excuse me. The patient simply might not have one, or that a hospital might not be able to identify one. There are going to be those instances where you can't identify who that's supposed to be. And in that case, of course, there's no required recipient for the primary care practitioner. Additionally, the rule includes this concept of need to know. If you look at the very top row, we've actually quoted the rule. It says the hospital must send notifications to those recipients that need to receive notification of the patient's status for treatment, care coordination, or quality improvement purposes. And that's intentional language, and it says those who need to receive notification. So there is some discretion on the hospital's part. If the hospital is able to reasonably determine that a potential recipient does not need to have that information, then that entity, that recipient, is not a required recipient. The hospital would not be required to send a notification to that entity. And third, I want to emphasize that the rule requires that a hospital make a reasonable effort to send these notifications. That's a standard that was chosen intentionally, and there's a discussion. There was a different standard that was proposed that was a little bit more strict, and the CMS very intentionally changed the standard to a reasonable effort standard. It's intended to allow flexibility. CMS specifically noted that they understood that some recipients might not be able to receive notifications, or as mentioned, hospitals might not be able to identify recipients. And given that hospitals can't control things on the receiving end, the rule accounts for that by requiring that the hospital use reasonable efforts on its end of it, on the sending side. As long as the hospital does use reasonable efforts to make these notifications, it would be in compliance. And then finally, notice on the last row, the rule expressly allows a hospital to send these notifications either directly or through a third-party intermediary. CMS identified HIEs as such of a type of an intermediary that might be used by a hospital to provide these notifications for the hospital. Obviously, this is relevant to this discussion today about how CliniSync can act as a intermediary in its HIE services to provide those notifications. CMS does permit the hospital to use services for these notifications and make even exclusive use of a third-party intermediary if that will allow it to comply with the rule. We note in that last bullet that the third party may act as the hospital in certain instances, meaning that they may exercise certain discretion that the hospital has in identifying and determining who's the proper recipient or required recipient of these notifications. Okay, you can go on the next slide. This is just a last slide for me, and I'll turn it back over. This was a snapshot of the memo that we did, which I know has been referenced. Scott has mentioned that that's an attachment. So if you have downloaded the attachments, you can see the memo in full. It's not that short. It's longer than that. This is just part of it. It does address some issues related to CliniSync acting as a third-party intermediary under the rule, and explores in more detail how that third-party intermediary concept would work and how a hospital can comply with the rule by using a third-party intermediary such as CliniSync to make the ADT notifications. So again, I won't go through that memo in detail, but it's there for your review or your information that you can read in more detail. Some of the specific questions regarding how third parties would meet the requirement for hospitals. Okay, I'll turn it back over and I think move on to the next speaker.
Thank you, Alan. My name is David Zupkovich. I am the Application and Web Services Manager here at CliniSync. We're going to jump a little bit into the actual process of the ADT notifications and how CliniSync facilitates the delivery of those notifications. So we're going to talk a little bit about the interoperability aspect of that now. So we'll go on to the next slide here, Scott. Before we do jump in, I did want to mention that a companion webinar on the technical aspects of Notify specifically will be broadcast this Thursday. We're doing another presentation September 24th at 1 o'clock, so same time. And within that presentation, we're going to be covering how to establish the notification panels for each practice and how a practice can customize the receipt of the notifications that they receive as well. We'll also be talking about the integration between Notify and our community health record, which is a separate application that we've linked to Notify to kind of aid people along in getting the information that they need. And then finally, we'll talk a little bit more about the audit functionality that Notify can provide for compliance oversight. So there is a link, and you can also find that on all of the CliniSync social media accounts as well. We'll hop on over to the next slide here, Scott. So CliniSync overall has the ability to send notifications to any identified provider that is part of any network, as we've spoken about. And we do this primarily by using our notification services. Now, the CliniSync notification services are comprised of Notify as well as Clinical Dispatcher. They're two separate tools. One is actually a web application. The other one is more of a process. But together, these notification services can help hospitals satisfy the requirements of the electronic notification COP, and they work to deliver event notifications to providers based on subscriptions that concern their patients. So providers who utilize these services, of course, can receive the event notifications for inpatient activity, emergency activity, and ambulatory events as well, amongst other things. But these notifications can be customized for each provider based on their preference. So, you know, we can have a provider receive all notices or only discharge ones or only emergency activities. The customization options are quite vast. Thursday, we'll be going over Notify, but what a little bit of a 30,000 foot up explanation of what that is it is a subscription-based web service, and that's what allows users to track their patient population through either a patient panel or we can actually do some matching based on the provider code as well. And that service provides ADT, the event notifications on the admission, discharge, and transfer alerts from our contributing facilities containing either health systems or hospitals. And then below that, you'll see that the other half of the CliniSync notification service package is Clinical Dispatcher. As I mentioned, this is more of actually a process. It's not so much of a tangible tool, but Dispatcher has the ability to deliver data in near real time using that similar population list that Notify would have. It's just a little bit more robust. And instead of providing an alert through a web portal, we actually can deliver the HL7 flat file into either an SFTP location or through a VPN tunnel as well. So basically what happens there is the patient is matched in our community master patient index, and we deliver that data right back. It's a much more integrated solution. So we'll go to the next slide here, Scott. Now, going back to Notify though, since we'll be doing a more in-depth demonstration on the technical aspects of that, I did want to mention that there's two primary big customization points that are available that Notify can provide. The first of which is that users have the ability to actually select the type of alerts that they would like to receive. So the data that we receive into our system from our contributing facilities gets categorized into one of 8 event types. Those event types are ambulatory, admission to the emergency room, as well as discharge from the ER. We have encounter update, inpatient admit, inpatient discharge, inpatient transfer, and patient death or expiration. So any combination of those alert types can be applied to each user's subscription, so that when they are subscribed to a specific population of patients, they have the ability to receive any combination of those, or one or all. And then over on the right-hand side of the screen, you'll notice that we also have a variety of delivery methods available as well. So the alerts that Notify can provide can actually be delivered via text message. We have the ability to set you up with a direct secure message, which will actually contain a little bit more in-depth information on the patient, information on the actual PHI side of things. But we can also set you up with a standard email, of course, which will let you know that you have an alert. And then we have the web portal access as well, which is always available. And these alerts are delivered on a prearranged schedule. So, if you would like to only receive an alert summary, let's say every day at 8 o'clock in the morning, you can do that. Notify will allow that to happen. And we'll move on to the next slide here. So this is just a screenshot actually of what the home page of Notify looks like. As you can see, there are a variety of filters that can be applied to a work list, and that work list sits down there in the middle chunk of the page. You can see here that we have a few lists of patient names there. We have the date that a notification was received, as well as the patient's first, last, gender, and date of birth. We have a column that highlights where the alert is coming from. So that's the source facility, and then also what the corresponding event type is to that alert, as well as a date when the alert actually occurred. So by applying the filters that you see on the top there, we have like a date range as well as a source facility selection box. By applying those various filters, that's actually going to impact the data that is displayed in that list. So if you just wanted to see notifications from a specific day, and you only wanted to see notifications from the Cleveland Clinic, and just have those notifications be emergency activity, you can do that. So it is pretty customizable, and that's we'll move on to the next slide there. Once you click into a notification, you're actually brought inside of it where you will be able to access 3 tabs. Those tabs are the notification tab, the event data tab, and the audit tab. You can see that those are aligned there on the left-hand side in that little gray menu. Now, we'll go into this, of course, more in depth on Thursday, but I did want to mention that there is a button once you click into the alert itself that will actually launch you, as I mentioned, into the community health record. So if we go to the next slide here, you'll notice that as opposed in just viewing the ADT and Notify, you can actually now jump into that patient's full chart where you have the ability to view demographics, their face sheets. You can now look at any results that we have, any sort of lab work, or transcription messages. There is quite a bit of information that you can access through the CHR. Scott, we'll actually go to the next slide here, and I'll also mention that users have the ability now to create CCDs or continuity of care documents on their patient too. And so we can actually create a CCD and users will have the ability to either download or print that, and we can even send that through a closed loop referral system. So it is quite a robust application to use. We'll move on to the next slide here, Scott. Thank you. So now actually I'm going to pass it on over to NOMS. They are the Northern Ohio Medical Specialists. And NOMS is a great client of ours. They have vast experience in maximizing the use of Notify and can actually help make the benefits of the application a little bit more tangible to all of you. So without further ado, I'll pass it along to Missi, Stephanie, and Michelle.
Hi, welcome everybody. I'm Missi Thomas and I am the IT project director here at NOMS Healthcare, which stands for Northern Ohio Medical Specialists. We do have offices throughout the state of Ohio. We have an office down south, close to the West Virginia line, and we do have one office located in Pennsylvania. So since we've went live and opened, we have started to branch out. I have along with me Stephanie Huntington and Michelle Naugle. Steph, do you want to speak up for Michelle? Maybe we can't hit them. Okay, can you guys still hear me?
Yes, we can hear you.
Okay, perfect. I'm not sure what happened to the other girls, but if you want to go ahead, we'll get started and go through the slides.
Yeah, for the team at NOMS, if you are muted, you will need to unmute yourself so that you can speak. At NOMS, you will have to unmute yourself. You are self-muted.
Okay, I'll keep going and hopefully they'll get started. So like I said, we were formed in 2001 and we started out with 32 physicians. We've grown since then. We're multi-specialty. We have 287 providers, 28 specialties. We also have a lab imaging center. We have physical therapy, just to name a few. We implemented an EMR in 2007. We've since upgraded to eClinicalWorks in 2014. As you see, we participate in the CPC Plus, Medicaid CPC, and Medicare Shared Savings and ACO MSSP. We went live with Notify in 2017. We receive an estimate of 5,500 notifications a month. So what we have done is we utilize Notify to contact our patients, letting them know that we had seen that they were in the ER and that they need to follow up with us. If they have any questions, we also tell them that we offer extended office hours. We have nights, weekends, and we also have urgent cares that they could go to. Anything to try to keep them out of the ER so we can decrease our ED utilization numbers. Stephanie and Michelle, are you guys able to speak now?
Again, guys, you have to. We heard you. Please proceed.
Go ahead, Missi.
No, Steph, go ahead and start with you pulling the panel, and then I can start with updating it.
Okay. As you can see, we have over 70,000 patients split into 2 panels. We have to do this because of the large amount of panels or patients that we have in the panel. We have an East and a West panel. We typically upload that to Notify about every other month or so, depending on how many new practitioners we are bringing on. We export that data from Notify and then put it into our EHR. We check that twice a day for our inpatient discharges. And for our ER discharges, we check it and contact the patient within 48 hours. And then we schedule them for a follow-up appointment as well.
So Stephanie extracts that data. She puts it into Excel format. We format it to ECW requirements. And then we have built a custom campaign within ECW. So we take all those patients that we're seeing in the ER that we pulled from Notify, and we have an automated phone message that goes out, which I had spoken about earlier. And we try to run that first thing in the morning, and we do that twice a week. Stephanie or Michelle provides that list to me, and we utilize that automated campaign. And by using the automated campaign, it saves us both time and money by running that automated, because the cost is, cents to run that through ECW versus having our staff call the patient, and then it turns into 20 or 30-minute conversation because now their toe hurts or something else. So they want to talk about 3 other issues. So we've gotten great results with that. And we've been doing that since, shortly after going live. So we've contacted lots of patients, and we've noticed our ED utilization numbers are going down as well.
And this is Dan. I just want to thank the folks from NOMS, because, again, they've been one of our most robust users in receiving notifications from the hospitals, and they've really done some great work. So I just want to thank them for joining today. Also, I wanted to talk a little bit about the post-acute care coordination efforts that we're working on with the post-acute care entities in different organizations. Next slide, Scott. Currently, most post-acute care organizations are receiving information in one of 3 ways, either through the transition care documents, through direct messaging, and we usually set up the direct messaging endpoints on behalf of the hospitals to the long-term care sites, or they're getting into the community health record. We are working on integration with a couple of the post-acute care larger EMRs, so they can also query directly from their EMR, and then also currently through Notify. Next slide. The specific use cases that were
And your audio is fading in and out a bit.
Hopefully this is a little better. The specific use case that we are working on with the post-acute care sites is really making sure that the post-acute care entities know the patient's been discharged. And there are a couple ways that we are working with them on that. One is, again, just communication between the hospital and the post-acute care site. The post-acute care site can add that patient onto their patient panel, then receive the discharge notification, or if they've chosen to receive it based upon the NPI in the ADT discharge notification, they can also receive it that way. But ultimately, it's just not the notification itself, but also the clinical data. Again, this goes back to the broader interoperability efforts that we're doing. But again, that information to make sure that the post-acute care site has all of the data they need to receive the patient and start the care plan. This is evolving. Again, we're working with the EMR companies that are most prevalent in the state to make this more integrated. And again, as we progress with that, we will keep you up to date. But again, these are ongoing and existing efforts going on in the state today. Next slide. Scott, do you want to finish off, or you want me to finish off this?
Go right ahead, Dan.
Okay. Again, attached, you will see some demonstrations for the notification tool that we have, the community health record. Again, we will work with any provider that wants to receive notifications, whether they are inside or outside of the state, and working with them on your behalf to best meet their needs. Again, but here's some demonstrations that you can see online. Next slide, Scott. And again, as I mentioned earlier, we're going to be having some additional webinars to talk about the broader interoperability efforts that we're working with you on around the discharge planning rule, which actually went into effect last November. And again, the information blocking rule with those entities that we're working with. Ohio really is an example of true interoperability at work. And again, anybody that is working with us should be able to hold up to any information blocking claim, in addition to the efforts that other efforts that you're undergoing with your EMR and other interoperability work that you're doing in-house. And again, another important one, the proposed rule, again, for your physicians that are, again, employed physicians that are working with us. Hopefully there will be another benefit in working with CliniSync to meet those rules. Those comments are just due. We expect those final rules to be out soon. And again, health information exchange is one of the proposed rules to meet some of the quality requirements. Next slide, Scott. And again, as Dave mentioned, there will be a CliniSync notification webinar coming up here in a couple days. If you're interested in that, please sign up. And with that, I think we're ready for questions. Oh, I'm sorry. Again, some additional webinars I forgot about. Again, the National Interoperability through Health Information Exchange in October. And we also are doing one with Public Health in November with the Ohio Department of Health. Next slide, Scott.
And we are working to finalize the schedule on some webinars that we're going to host after the first of the year as well. We don't have the dates, the times locked in, but once we do get those on the schedule and the GoToWebinar registration sites created, we'll distribute that information to all of the attendees of today's webinar. First, would like to thank everybody who participated today, both the attendees and the speakers. Very, very much appreciated. We are now going to open it up to questions. And as a reminder, we want to use the questions feature of GoToWebinar. Just click on questions, click on chat, put your question in there. We're going to take the time to read everyone, and we do have a few questions right now. First question, and this can go out to any of the presenters that feels best suited to answer. Just please unmute and answer the question. But the first one is, does this condition of participation standard apply to freestanding EDs?
Do you want me to
Alan,
answer that?
you're probably one.
Yeah, Alan, if you could take that.
Sure. No, it does not. So assuming that it's not part of a hospital, a lot of freestanding EDs are provider-based, so would be considered part of a hospital. But if it's truly freestanding, meaning it's not just located off campus, but if it's truly freestanding and it's actually an ED and not part of a hospital or not a provider-based unit of a hospital, it would not be a requirement for that freestanding ED. Again, in Ohio, at least, most of the quote-unquote freestanding EDs are actually off-campus hospital provider-based departments. And so as part of a hospital, it would, in that case, it would. So if you are asking about that, where you are provider-based location, you're still part of the hospital. So like any other provider-based off-campus location, you still have to meet all of the hospital COPs, including this one.
Thank you, Alan. Next question. Does a home care agency need to receive a notification if they are providing care to a patient? And how about a supplier like home oxygen or DME?
Alan, you want to take that one?
Do you want to go again? Sure. So the home health agency, a home health care supplier, if they are a post-acute care supplier under the rule, meaning they're going to be receiving a referral for that patient, and they're going to be taking care of the patient after discharge, they certainly would qualify as a post-acute care provider or supplier. A DME supplier, I'm not sure I've seen that referenced under post-acute care suppliers. I don't know that that's the type of provider that has sort of an ongoing treatment relationship as opposed to a more temporary relationship where they're providing one piece of equipment. So I haven't seen them referred to. Now, I will say post-acute care facilities is not specifically defined in the rule. It's not like there's a list and it only says these 5 types of providers. So the real criteria is going to be whether or not they're a healthcare provider that immediately post-discharge is going to be receiving the patient for treatment.
Okay, next question is, do we have to demonstrate a certain percentage of our admitting providers receiving a notification to meet the COP?
No, that CMS, this is Alan again, CMS specifically elected not to use that type of a measure where you would have a percentage or a certain number, and recognizing that that is something that's used in the meaningful use world and promoting interoperability world, where there are measures where you have to show 25% or a certain number of patients. They did not do that here. So this is just a regular COP. So in theory, that's actually a harder requirement because you have to show everybody. It's a 100% rule. They would not say you get a passing grade if you can show a certain number of folks receive these notifications. CMS noted that they're going to use standard survey and certification methodology when they survey for this to allow a hospital to demonstrate that they meet the rule. So, records review, they might pull records and say, can you show me where this patient had a discharge that was sent to their primary care practitioner? And so they specifically elected, they addressed that issue in the commentary, and they specifically elected not to use a threshold percentage type of a measure. And again, that's why we want to emphasize the reasonable effort standard as well, because there might be very good reasons why in certain records polled, you don't make any notifications. The physician was unreachable. They don't have the technology capable of receiving these notifications, for example. So you should be able to still meet the rule, even though there isn't 100% compliance, but they didn't set a certain percentage threshold.
Yeah, and this is Dan. Let me just add to that too. The vision here is that, again, as we showed early on, we're already sending a tremendous amount of notifications to providers in the community on the hospital's behalf. Again, the hospital would just make sure that the providers in the community knew if you wanted to receive notifications, to contact CliniSync, and we will get them set up for that. In addition, as I mentioned, those reports that are currently being sent to each hospital on a quarterly basis, we can also provide the detailed information behind those reports to provide which practice and physician that those notifications went to as well. So that documentation is, the detailed documentation is also being developed right now.
All right, next question.
Yeah, I'm sorry, just one other quick thing. We didn't talk about it today, but I sit on the board of Direct Trust, which Direct Trust provides the transport protocols for, your transitions of care, documents that are being sent out in the community. There's also a current work group created by the HR vendors, and we're creating a set of direct standards to allow these to flow inherently through the EMR vendors as well on your behalf. And again, those standards are just being developed and there'll have to be some work done. But again, we believe that that'll be another important piece of this as far as being able to check a box, and we'll keep you up to date as far as that progresses as well.
All right, next question is, does this condition of participation place any requirements upon ambulatory facilities or providers?
Alan?
So this is Alan. Yeah, so this is Alan. No, I mean, this is just one piece of the interoperability rules, of course. So there might be other components which do, and certainly there are going to be, information blocking issues which are going to apply to everybody, not just hospitals. But this specific rule, just the ADT notification rule, is a hospital rule. It's a hospital condition of participation, and it's a sender rule. So no, as mentioned earlier in the slide, if you're an ambulatory surgical center or an outpatient clinic, you don't have any obligations from a regulatory standpoint under this. Obviously, the goal is for you to be able to receive messages, and it's an attempt to facilitate coordination of care issues. So hopefully you benefit from the rule in the sense that you will be able to get more of these types of notifications from hospitals. But the rule itself applies to and provides or imposes legal obligations only on hospitals.
Next question is, who is responsible for keeping up the customization for each physician? And we may need a little bit more detail on that from whoever submitted that question. But I think the question here is, how does the system know, how does the CliniSync system know who to deliver the alert to?
I'll take that. So when we provision users within, let's say, the Notify application, we create an account for them that receives those alerts by way of subscription. So we have the organizations that we build as subscribing organizations. Each one of those organizations then has an attributed patient panel, and their users have subscriptions to that panel. So basically, when a notification is generated, when a match is made on the ADT that's coming in and a notification is generated, it looks at who is this patient, who does this patient belong to, which organization does this patient belong to, and then the next step would be who at that organization is going to be receiving this alert. So if there are 3 people at the organization who are all meant to receive that same alert, each one of them will receive a notification when they log in, or whatever other delivery method they have. But to answer the question a little bit longer way, it's basically all set up on the back end. We will go through the implementation process with the client and iron out all of those variables.
Yeah, let me also add.
So Dave, what you're saying is that oh, go ahead, Dan. I apologize.
So it's really the customization is between CliniSync and the subscribing provider or practice, and that practice will determine how they want to receive the alerts, what alerts they want to receive, and how they want to be identified. And that can be done either through a patient panel or through the identification of the physician on the ADT notification. It's really up to the provider and the practice. And 95% or more of the current notifications we're sending out, the practice has chosen to use a patient panel as opposed to just receive all notifications anytime they appear on a registration message. But it really is up to the practice and the provider to make that determination. So we will work with them, and the hospital doesn't have to worry about that.
Okay, we have just a few more questions here, and we do have time. We're 5 minutes from the top of the hour. Next question is, if a specialist, such as a surgeon, admits a patient, does the patient's primary care provider need to receive the notification as well as the surgeon?
So that I can at least give my thought to, and anybody else can jump in. But yes, if the rule is related to primary care practitioner, that's the required recipient, or the practitioner that's primarily responsible for the patient's care. Now, I suppose you could have a situation where there really was no primary care practitioner, and there was only one. There was a specialist who was the physician that was primarily responsible for that patient's care. So I think that you might have situations where that was the same person, and obviously you don't need to send it to the same person who admitted that, referred that patient for admission. But it is assumed that those are different people, so that there would be a primary care practitioner and a specialist. And if there were, which I think that question presumed, that there was a regular primary care physician in addition to a specialist, the specialist is the admitting physician, then the primary care practitioner should receive that notification under the rule.
Thank you, Alan. And it looks like our last question. This one's for the team at NOMS. Can NOMS talk some more about how they combine their data from Notify with the information that they upload into their EHR, and how you go about, performing that combination of data that gets uploaded? NOMS team, you will have to unmute yourself if you've self-muted.
Okay, Stephanie pulls the data from the Notify, and Stephanie, do you want to talk about how you copy and paste that?
Yeah, really, I believe the question is, what's your process? What data are you combining together with the data from Notify, and what are you uploading into your EHR?
We're uploading the notifications that we get from Notify of the patients that have been discharged from the emergency room. So Stephanie pulls that list, she copies and pastes it into an Excel spreadsheet. We then format it into the required fields for ECW. We need a cell phone, we need a patient email, we need to know if they're web enabled, we need to know their birth date, we need to know the primary care provider's name, and we have to put it in a specific format that ECW requires. And then we have built that custom campaign in ECW based off the required fields, and we have that global standard message that we attach it to. Now, you can send a portal message, we could send a text message, we could send multiple modalities, but we have chosen to only send a voice reminder message because we've had, the best luck with that, and we're not being charged for all those separate modalities. We upload that, and within 5 minutes, the calls start going out. And typically, like I said, we run that twice a week, and typically we have, 60 to 80 patients that have been seen in the ER, which isn't too bad considering, we have 267, I think we're up to maybe 270 providers as of today. And again, we see more during flu season, but it's sporadic how it goes in spurts.
And I would like to once again thank all of our presenters for taking the time to share their stories, share their information, and share their expertise with the attendees. And also, thanks to the attendees for joining us today. We will be sending out a copy of today's slides to all attendees, and we'll be uploading a recording of today's webinar to the CliniSync YouTube channel within the next couple days. So again, thanks for attending.